I am going to get you promoted here. All right. Can you hear me? Allow to talk. Okay, there we go. Are you there now? Oh, you went on mute.
There we go.
We knew we would get it, right?
Yeah, eventually.
Eventually. How are you today?
I'm pretty good. How are you?
Good, good. I am going to start with our a full introduction because we have a lot of new members,
Okay,
and
perfect.
that might take a little bit. I'm going to try to hurry,
Okay,
and then we'll get to the questions, and I've cut them down to
okay,
the ones
perfect.
needed, and we'll see how long we have. All
Okay,
right.
sounds
Well,
good.
we'll start with our introduction, which we all know you are Dr. Karen Herbst. But I wanted to start with that you are board certified endocrinologist, internationally recognized lipedema expert,
Mhm.
head of research director of diagnostic and preventative medicine at the Roxbury Institute,
Mhm.
vice president of the Lipedema World Alliance.
I am no longer the vice president.
Okay, well, we'll take that off
Yeah,
because I'll
my
with the group.
my my term ended and now it's Shelley Crescenzi from
Okay,
UVA.
okay. I appreciate that. We'll delete it because I'll be giving this to the group also. So no
Okay.
worries. A prominent board certified endocrinologist, serves as the head of research at the Roxbury Institute and is home to the advanced lipedema treatment. And do I say alt? Is that how we say it?
Yeah, I say ALT, but
You do?
yeah,
Okay. ALT
alt
plus.
sounds like salt.
Yes, it does. I was going to say that. And then I thought, I've never really heard it said. We always
Yeah,
say Roxbury.
right.
So,
That's
yeah,
easier.
program. Um, you lead as the director of diagnostic and preventative medicine at the Institute's center in Tucson, Arizona. Beyond your roles at the Roxbury Institute, you hold the position of, okay, no, we're taking that off, right? The
Right.
Alliance, president of the Alliance. Okay. I pulled it from the Roxbury site.
Yeah,
So
we got to change that. That just happened, by the way. So,
no worries at all. We got it. Um, so you collaborate closely with Dr. Amron to redefine care for patients by mapping and creatively addressing gaps in research, accelerating the development of novel therapies, and broadening access to clinical breakthroughs. Your innovative approach not only pushes the boundaries of human investigation, but also empowers ALT providers to apply the latest insights directly to patient care, enhancing treatment options for both new and existing patients. Under your leadership at the Diagnostic and Preventative Center, co founded and developed with Dr. Amron, Dr. Herbst advances comprehensive care strategies that merge expert guidance with diagnostic and preventative methods. The center is dedicated to diagnosing and preventing the progression of lipedema and other fat disorders, making a substantial impact on the advancement of the field. Dr. Herbst is at the forefront of unraveling the complexities of lipedema, Derkham's disease, and other diseases of adipose connective tissue, focusing not just on lymphatic and vascular comorbidities, but also the metabolic and hormonal factors, dysregulation of immune system, and the genetics underlying chronic disease, including hypermobile joint syndromes, mast cell activation diseases, and others. Your commitment uh, extends beyond traditional surgical interventions, and as she integrates cutting edge research with advanced diagnostic and preventative therapies, significantly enhancing the Roxbury Institute's multidisciplinary approach and achieving transformative outcomes for patients. internationally recognized for your groundbreaking research. Dr. Herbst has spearheaded significant advancements in understanding lipedema, Durkheim's disease, and other related conditions. Notably, led an NIH-sponsored conference in 2019 to establish the standard of care for lipedema in the United States, and was instrumental in the introduction of the ICD-10 codes at the CDC in 2020, marking you as a pivotal, I can't say words sometimes, pivotal figure in global healthcare discussions. Recently, you were awarded with the 2024 PRS Global Open Best Paper Award for Best Reconstructive Paper, recognizing her as co-authored work on the significant impact of lipedema reduction surgery. Dr. Herbst completed your PhD in cell what is that word?
Physiology.
Physiology at the university. I studied so much, and there's a lot of words in here.
Yeah, I know.
At the University of Iowa, followed by a prestigious Howard Hughes Fellowship at the University of Utah. She then completed her medical degree at Rush Medical College and your residency and combined research and clinical fellowship in metabolism, endocrinology, and nutrition at the University of Washington, an innovative campus known for receiving more federal research dollars than any other U.S. public university. With a distinguished career spanning over 2 decades, Dr. Herbst has held faculty positions at Martin Luther King Jr. Medical Center, UCLA, the VA San Diego Healthcare System, UCSD, and the University of Arizona, where you led the TREAT program, focusing on adipose tissue and metabolism. Recognized with a Lifetime Achievement Award from Tucson Business in 2019 and named one of America's top physicians, Dr. Herbst's innovative approach and dedication make significant contributions to the treatment and understanding of connective tissue diseases. Amen. She's now licensed in 20 states, which I have shared with the group, so that is posted there, which significantly expands access. She's written or co-authored at least 6 to 8 books or comprehensive guides related to lipedema, lymphedema, and general health, including Lymphedema and Lipedema Nutrition Guide, which she co-wrote with 6 authors, one who is very dear to the Durkheim's disease community, Linda Ann Pont. And last but not least, Dr. Herbst is a prolific researcher who led the creation of the first ever U.S. lipedema standard of care guidelines, which included 85 consensus statements. Whoa, that was a mouthful.
There's more.
So I appreciate you helping me out with a few of those words. So we are here to ask you some questions, and you have graciously agreed to give us some answers. We understand that some of them may not be the answers that they are looking for, but they are the honest, truthful, and needed answers for each question. So are you ready to get started?
I am.
Okay, I'm starting out with a larger one from Kathy, and I am trying to pronounce names too. Latau, it's either Latau or Latau. The question is that she has stage 4 abdominal wall endometriosis and Durkheim's disease. I've noticed that there is a correlation with these diseases. I've had so many tumors growing in my stomach. I've had over 156 tumors removed from my body since 2016. I still hurt so bad. We need a better way of finding these hurtful little things. I can feel them under my skin. My doctor can feel them under my skin, but they're not showing up on any type of imaging. Because of them not showing up on imaging, it delays having them removed, and the longer that they are in my body, they're pushing up against nerves and causing tons of pain. My dermatologist has suggested to start taking GLP-1 medication. This really scares me. I have so many problems with pharmaceutical medications to the point to where I've been put into the emergency room because of it. I even carry an EpiPen. Just wondering if I would have any success with GLP-1 medication without a ton of side effects.
So thank you so much for that question. It's complex and it's something that I would say we work with patients on these same issues all the time. It's a little, I could use some more information. For example, I'm not clear if the lipomas are angiolipomas versus lipomas or a mixture of both. That would make a difference for me. Also, I don't know if she has mast cell issues, and endometriosis is often associated with mast cell issues. So I would guess that's a good possibility. So with that said, she may or may not tolerate a GLP-1 receptor agonist. We use these a lot. Like a huge part of my practice is prescribing these medications and tweaking them so that people can tolerate them better and get good outcomes in terms of their health. So I would say that yes, I think starting a GLP-1 receptor agonist would be a good idea. To try, especially because she has so much pain. And these are just great at reducing inflammation and reducing pain. They also are considered, at least by me and by others, as treatments for mast cell. So whether you have just more mast cells than the normal person on the street, or you do have mast cells that are hyperexcitable. I would say she would want to start on a micro dose. And we have people that, so you can get GLP-1 receptor agonists either as pens, or you can get it as in a vial. And I like the vial for people to start with. And so let's say the starting dose is 2.5 milligrams for tirzepatide, which is my preferred GLP-1 receptor agonist due to lower side effects than the others. If she were to inject the full 2.5 milligrams, that would be the whole vial. That would be a half a mil, but it's also would be about 50 units, 50. I think it would be a good idea if she started at 1 unit. And that way she could just see how she tolerates it. I also have compounded tirzepatide and semaglutide at even lower doses than the vials, and then had people inject very small amounts of those and work their way up. So I don't think you're restricted to the 2.5 milligram starting dose or the 0.25 milligram semaglutide starting dose. And then some people have reactions to where they inject. And so you could split it. You could give half of the dose on Monday, half of the dose on a Wednesday, so that you're not getting some of those side effects. But you would definitely want to work with your provider very closely and just keep in touch, because side effects happen that you don't expect. Am I right, Juanita?
Yes, yes, as I'm wearing my little computer glasses. Yes, ma'am.
Yeah.
Yeah, it's just one of those things that happens, especially when you have mast cell, like you said, and with her, with the pharmaceutical, where she carries an EpiPen, you're absolutely right. She
Yeah.
would have to start at that 1 unit, and I wouldn't start anything more than that from
I wouldn't
experience.
either. And if her provider will not give her the vial, then I would go somewhere else and try to get it from somebody else. But you definitely need to be super cautious. But why do we think it's worth it? Because it is one of the most potent anti-inflammatories that we have, and it's worth a try. If you can feel any better on it, I think it's worth a
100%.
try.
I agree with you 100%.
Mhm.
Yes. Thank
But
you.
as I said, we need to know what kind of lipoma she has. And if she has angiolipomas, there are other things that she could try.
Okay. Okay. Well, we'll do a follow up with her, and I'll find out. Uh, all right. The next question is from Crystal Burge Vaughn. What type of exercise do you recommend that won't cause tumor growth? Which I'm like, oh, I don't think there's any, but cause tumor growth. But I'll leave that
Well,
to you.
that's interesting that you bring that up. We're just talking about some genes that are pretty common in people that kind of dictate what kind of exercise that you would do better with. So some people have fast twitch muscles, some have slow twitch. And if, you have one or the other, you may either do well with high intensity exercise or you would do better with low intensity exercise. So what I recommend would be something very gentle to start, like whole body vibration. That's
Mhm.
great exercise. It causes all of the muscles in your legs to contract and your hips and your butt. You could even put your arms on it too.
Yep.
The downside to that is if you have mast cell issues, it can activate your mast cells. Swimming is also awesome if you feel comfortable getting in a swimming suit, going out in public, or if you have your own pool, or if you just got into a tub of water and moved around. That really helps move the tissue very deeply all the way down up next to your muscle. Or an elliptical, or just walking, gentle walking, wearing some compression garments, gentle weightlifting just with your arms to start, just doing some chair yoga, maybe even Tai Chi. And I think movement is so important, but I agree sometimes it can make things worse for people, especially if they generate a lot of lactic acid or if it causes their connective tissue to pull, rip, or tear. So
Yeah.
I've been doing quite a bit of reading about an amino acid called glycine.
Hmm.
And one of the first treatment papers ever published on Derkham's disease, I think it was back in 1929. I have to go back and look, but I mean, it was like way back in the day. And they had three women and they gave them uh, adrenergic, no, acetylcholinesterase inhibitors so that their norepinephrine would stay in the nerve longer and so they'd get more firing. And they gave them a diet and they gave them glycine. And glycine is an amino acid. It makes up about 1/3 of the amino acids in collagen. And so if you take glycine, it's been proven that you get more collagen in your body. And it's very inexpensive. It's got a little sweet taste to it. You can
Hmm.
use as little, you can buy the powder so you don't get any excipient ingredient, so you don't have to worry too much about mast cells getting activated by the junk that's in the supplement. And you can use a quarter of a teaspoon or an eighth of a teaspoon after you work out. And that will help promote, it'll take all your metabolism and drive it towards making more collagen, and it helps prevent muscle wasting. So I think that it is the exercise that you do that's important, but perhaps if you used a little glycine after any exercise that you did, it could make you feel a little bit better after the exercise because your body's going to go into making muscle, making collagen mode rather than, hey, let's inflame you mode.
That's amazing. That is really
Mhm.
good because I do take glycine, but I literally just switched to the powder. And there's a Dr. Herbst, what is it? There's a bio something type of the powder that it's better for people that have reactions or mast cell. I just started taking it. I'm not kidding you this morning.
Wow.
Yeah.
Good
Yeah.
timing. And yes,
Yes.
it would be
Exactly.
great to add into a protein shake. And you can take, I think you don't want to take more than 500 milligrams uh, per kilogram body weight, which would be like 30 grams a day just for me. And
Yeah.
I just don't think I'm ever going to take 30 grams of glycine. And especially if you're taking 1 gram at a time. And I did take 5 grams for sleep and it totally relaxes you. It's pretty amazing stuff. So
Awesome.
maybe 1 gram won't help you after exercise. Maybe 2 grams won't, but maybe 5 grams will. So, take it
We
slow,
know
take it easy, work your way
exactly.
up.
We know we have to do that. We have to
Yes.
do that, especially a lot of us with the mast cell. So I love this. Thank you. Love it.
Hmm.
All right. Next question is from Sabrina Strayer Roberts. She's been diagnosed with Derkham's for a long time. Other than pot, melatonin, or drugs from a doctor, what do you recommend for sleeping because the pain keeps her up?
So right back to that, we recommend magnesium glycinate, and that's magnesium bound to glycine. So, and I'm not sure you can get that as a powder. You might, oh no, you can from Thorne. Thorne has a good magnesium glycinate, but you could probably get it from other companies as well. And like I said, I took 5 grams. That was helpful. But when you combine it with the magnesium, you have to watch for gut issues because magnesium can help you go to the bathroom. So just
Yeah.
glycine alone, magnesium glycinate. And then I know this is by prescription, but low dose naltrexone. I'm sure many of you have at least tried low dose naltrexone. And that
Mhm.
either, it works for some people amazingly, and for others it does not. And some people feel groggy the next day, others do not, but that would be something you could try. So, and it's the pain, yeah. The other things that I recommend are non-pills, such as PEMF mats, pulsed electromagnetic field mats. Those are amazing. It's just a the technology is very simple. It's just the electricity just bounces back between plus and minus, and if you hold the mat up to your ear, you can hear the tick 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 tick, and that
Oh,
just starts to heal your tissue and calm your nerves down. It's kind of like watching a ball go back and forth. Like you kind of focus on it, but your whole
yeah.
body focuses on it, and it's really great for healing. Those mats can be expensive, so you just got to shop around. And some of them sound very woo-woo, like they put crystals in them and red light therapy, and I wouldn't not buy a mat just because it had woo-woo crystals in it, right? So I
Sure.
don't think it's going to hurt you or in any way or change things. It's still got the PEMF in it. And then red light therapy is also a great way to help reduce pain. Um, I have like a handheld red light therapy that I use because
Mhm.
I'm hypermobile and I have joint pain, so I treat some of my joints at home, and the red light therapy helps with that. The other thing I've used for pain that's not something you put in your mouth is, and again, I'm sorry, this is a prescription and you're asking for something different, but this is just information for you to have is I get pentoxifillin and I put it into a cream that's very well absorbed into the body. And there's a couple of different kinds. Permeate is one, and then I think there's a lipid mixture. And the compound pharmacies know this, and you can rub that on your tissue, and that is an anti-inflammatory. And I've got quite a few people that actually keep asking for refills, so there's got to be something to that.
Something to it.
Hmm.
Okay. That's great. I mean, yeah, and that's the thing, right? We're all different. So,
Yes.
we have to keep trying things. That's part of the game with us.
Yeah. I mean,
We're
I
all
don't
different.
know. I don't know like I mean, the um, CBD and THC are really great for pain, like you're doing, and the melatonin is as well. But melatonin can, some people don't tolerate it. It makes people
Right.
groggy the next day, or they just feel sick on it. So It, it's
Yeah.
it's hard. The pain
Mhm.
is so hard. I'm not a pain specialist. Um,
Yeah.
the only other thing I could say about that is that some people have had very good results with hot and cold. So taking a
Mm.
hot shower and then doing a cool for women or a cold plunge for men and going back and forth. And that is an excellent anti-inflammatory. So that would be something you could try. And also just to calm down the vagus nervous system with deep breathing. And then
Right.
cold facial plunges also help.
Deep breathing is so big for people. I always tell people, don't forget your vagus nerve. Do your deep breathing. It's so big.
Yeah, I think a lot of us just breathe, and use about a tenth of our lungs and we're just constantly just starving for oxygen. And
Do it
we
all
know
the
that
time.
Durkheim's tissue is hypoxic. I mean, let's be real. It's very hypoxic.
Yeah, I totally agree. I forget to deep
We
breathe.
we actually have a cycling hypobaric chamber, And I don't know where you live, but it's through a company called CVAC Systems. It's C as in cat, V as in Victor, A as in apple, C as in cat, and then systems. And you can look up where you can take a session, and they're relatively inexpensive. And it improves your fitness, and by improving your fitness, it may decrease your pain. And I use it for gut issues. If I have, I use it every day because it improves my fitness and I want to live and age well. But
Yeah.
it also, especially for IBS symptoms that can really make you feel like crap and cause pain, it is one of the best treatments because it reduces inflammation all throughout your gut within a 20-minute period. And that's a deal. If you ever have been kind of bent over with IBS symptoms, you know what I'm talking about. 20 minutes and it's gone. That's a miracle.
Never heard of it. I'll have to look that up with my
And
IBS and my diverticulitis stuff.
oh yeah. Yeah, it's not a hyperbaric, it's a hypobaric. So you
No.
sit inside of a pod and a vacuum pulls air from around you and puts it back in. And I did a research study on it and it's been published. You can look it up. And I guess you could look up my name and the word hypobaric. And I had 10 patients with Derkham's disease. And I will tell you, after I first put them in, they detoxed. And so their pain actually went up. And I
That's good.
was early in my research career on my own. And I was like, what am I doing? I'm supposed to do no harm and I'm harming these people. They were vomiting going home. And
Oh,
then, yeah, I mean, it was bad.
yeah.
But that was only for a day because I only had them for a week because a lot of them traveled in from out of state. And then after that, their pain went down, 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 down. Their mo
That's,
their physical mobility went up, and then but not their mental. So I did a couple more people after I published the paper, and we got a significant improvement in mental health as well.
that's
So
amazing.
no pill. You just have to be able to
Awesome.
clear your ears because there's a pressure change around you. And if you
That's
ever come to Tucson, we'd be happy to run you here.
awesome. There you go, Sabrina. That is amazing. So that's really good stuff. I don't think we've talked much about that. So that's
No.
a really good one. Okay, we have Anne Rachel K. With hundreds of lipomas in my rib cage and near my right shoulder joint and throughout the scapulas, how do you explain that you are not a drug seeker? The pain is so awesome at times, I can barely breathe. I think the problem is I look normal. I'm a typical Ted head redhead. I think she means redhead. I think it's a
Yeah.
typo.
Yeah.
That can take a significant amount of pain. Yeah, redhead. But I also metabolize medications more quickly than most. Why won't pain management see you? Because there's no cure for Derkham's. Isn't that the point? That we need pain management. Help.
Yeah, so this is one it would have been nice to have a little bit more information just because I feel like for somebody like you, I could write a really good referral and get you into medicine. I don't see what the problem is. Um, you can't just say refer for pain management and not explain who you are, what you've done, all the things you've done, and you're unsuccessful. So obviously, you said you metabolize medications more quickly. Um, Before you went, I would run a genetic panel on you if you have not already had one done and see what medications, um, how you metabolize medications to give some information to the pain specialist. But I don't see why you can't get into a pain specialist. You just haven't gotten the best referral. I think that's my opinion. And also, if a pain specialist won't see you, fine, go to another one. They're not the right one for you.
That's perfect. All right. Amber Moore McCoy. How do we, as patients, get plastic surgeons on board with liposuction? A plastic surgeon I had uh, to take out 27 lipomas told me that liposuction is not good for Derkham's disease. But the dermatologist that diagnosed me said liposuction is a good treatment plan.
Mhm. So I used to write referrals for patients with Derkham's disease to get liposuction before I was linked up with surgeons who do liposuction, and now I don't have any problems. But I would write a letter and put down all of the papers that show that liposuction does improve pain and other indices for patients with Derkham's disease. So again, that's kind of on your primary care provider or whoever is referring you to write that referral, and you could help them by going to the literature and finding all those publications on liposuction for Derkham's disease. And a lot of them come out of Sweden. I think they've done the most work on that. And there's like our providers do liposuction for Derkham's disease. I know some others in California do it as well. And then there's some on the East Coast that will do it. So I think you also need to find the right plastic surgeon. And I know insurance dictates that a lot of the time, and that's unfortunate. But if your surgeon isn't doing what you want to do, then try to get your insurance to pay for one that will do it. The only thing I'll say is that if you have Derkham's disease that's super, super fibrotic, it's going to be very difficult to get all that out through that little tiny cannula hole. So the best thing to do is to get that tissue as soft as possible with an anti-inflammatory like a GLP-1 receptor agonist. We also use enzymes to reduce the fibrosis in the tissue, like nattokinase, serrapeptase, lumbrokinase. Anything that you can do, manual therapies as well, to get the tissue soft enough to get up through that cannula. Otherwise, there's other surgeons that will fillet you open. And I'm just not a big fan of that. And I do think there's, you basically need to have tumescent liposuction fluid put into your tissue, and you need to sit there for hours and let it really soften up your tissue before you would do well with the liposuction. And that's what they do in Europe. Here in the US, what I've noticed is they tumesce and then they go. So
that's interesting.
Just be careful. But I think it's partly on you and your referring provider to soften up the tissue. And then it's on the plastic surgeon to know really how to treat Derkham's and not just say, okay, I'll just do it without really, talking to another surgeon and getting good pointers on how to do it correctly.
Makes sense. It's good to know. Because, we just, it's so controversial in our group because you have so many people that have good, experiences, some that don't. And it's just, once again, it's just each of us are so different, right?
Yeah.
And we have to make sure we know what we're asking for and that we've done our research and help make sure that it's done correctly. So that's good information about the softening.
Mm-hmm.
Okay, Katie Swartz. If there's a way to get more providers educated, that would be a huge help. I feel like I'm always battling my doctors and I can't trust them because they have no clue what they're talking about with my conditions. How can I trust their treatment options when they don't know what they are treating? Thanks for all you do, Dr. Herbst.
1:36 p.m.
So I think the best way to get more providers educated is to publish more papers in this area, because the more data we have, the better. And instead of like, here's a case and a review of the literature, here's another case and a review of the literature. I mean, those are good. Cases are really good, but they're not really providing treatment guidance, I guess. And I will tell you, I've been doing this for over 20 years and I have my protocols, but sometimes I feel like I'm throwing darts because you look different than my other Derkham patients, but yet you have lumps and bumps in your tissue. They're very painful. You've got MCAS, you're hypermobile, you've got POTS, and you've got these big lumps. Why do you have that? So more recently, in the past year, we've been doing genetics for patients, and we basically data dump down from sequencing.com, and then we plug it all into AI, and we have come up with treatment protocols that I would never have thought of, because I'm only one person and I don't know every single supplement and everything that you do with them and all the ups and downs. So I know AI is controversial, and I don't believe everything it says, and I look stuff up myself and verify myself, but some of the treatment recommendations are astounding and so individualized. So it's not like throwing darts anymore, which I really like. And
Me too.
I had a patient this morning and I didn't tell AI she had POTS, but because I plugged in her gene set, it said, oh, she's got MCAS and POTS. And I'm like, are you kidding me? How did you know? And hard of hearing. I'm like, how did you know that? So
Because of her genetics.
that's where we have to go because just like you said, Juanita, everybody is so different from everybody
Yes.
else. And that's what makes Derkham's disease such a mixed bag.
Yes.
And
Yes.
so how can you personalize it to you so that your provider doesn't even need to be educated on Derkham's disease? They're going to treat you because you know of your genes. I think it's at
Yes.
least one good avenue. And it's pretty inexpensive to do the genetics. And
Yes.
you
Yes.
can look for the big bad genes. So what I look for are, just as a start to help you out, look for the terminations. So when a protein gets terminated and you just download all your DNA and then look for the word TER.
Uh-huh.
And then duplications, look for DUP. And then frame shift, look for F as in Frank, S as in Sam. And that will give you about 10 nasty genes. And that would be a brilliant start to giving you new insight into you. And that you can bring to your provider. Like, hey, I have a hemochromatosis gene. What are you going to help me with that? Hey, I have this other gene and it says, and it gives you data to share with your provider so that you actually bring things to them and you educate them. And I'm sorry, that's where we are,
That's really, really good information. Really. That we haven't talked about before in our group that I don't recall that at all. So that's very,
I could not do it without, I can do
yeah.
lipedema. I can do
Yeah.
lipedema. But I also have done the genetics of more patients with lipedema than anybody else. I have,
Mhm.
my goal is to figure out angiolipomas and then I can retire. And so I am desperately trying to find those genes. And
Oh,
here's the take home message from what I found. Everybody is messed up. And it makes sense. How else could we die? There's no other way that we could die if weren't all messed up,
yeah.
right? And age, right? Otherwise we'd be
Right.
perfect and, we would live
Right.
forever. So we are
Right.
designed to die. We all have problems in our genes. I've put
Yes.
mine in there and I'm worse than most of y'all.
Oh my
So
God.
I look worse than most of the people with Derkham's disease. So that just gives you a hint that,
Wow.
yeah, you look at someone with Derkham's disease and then you look at me and you expect me to be better, but I'm
I
not.
do. I
And
do.
so it's very, very personal. And
Mhm.
there's so many different ways to get to Derkham's disease because Derkham's disease is it's unhealthy fat, it's sick fat, it's inflamed fat, but the fat is there trying to protect you. It's telling
Mhm.
you something is wrong,
Mhm.
but what is that? So you have to search for the starting point, which is hard when everything is subclinical. And
Mhm.
so, yeah, so this morning we found out for my patient that she had some underlying autoimmune lymphoproliferative syndrome. We also found out, God, she had something else. She had an NF kappa B1 variant, and NF kappa B is one of the biggest inflammatory pathways in your body. It's like everything leads to NF kappa B, and she had the NF kappa B1 actually keeps everything nice and calm. Hers was bad, was pathologically
Mhm.
bad, and there were only like three other people who had an NF kappa B1 variant, and they're all lipedema, and so it's rare and it was very damaging. How would I have
Mhm.
guessed that? In a million
Mhm.
years, I couldn't have guessed that.
You couldn't.
So
Yeah.
so even if we educate providers on what Derkham's disease is, that's not the answer.
That is so true. And we have been talking more in genetics in our group too,
You
because
guys
it's
ought to all do your genetics and have a
Mhm.
party, and I'll
Yes.
teach you all how to bring it onto an Excel spreadsheet. And then I'll teach you how to look for the big baddies, and then I'll teach you how to use AI, and then you can at least start from there.
Awesome. I love it. I'm sorry, but I could not, I couldn't self advocate the way I am now without it. I've learned a lot.
Hmm.
And I've dumped some of the genetics in there. So I totally get it. I'm not a proficient at it as you, as those codes you were saying to use. I'm not that far, but I did learn a lot.
Have you
So
done your sequencing.com?
I'm one of those weird ones that it didn't take for some reason. It wasn't
Oh,
anything.
you
So
just
then
need to scrape harder
I do
on your
need a
cheek.
sweet harder.
Yeah,
Okay,
on your
I have
cheek.
one here. I just haven't opened it yet.
Yeah,
So
just give it, I mean, you can take when you take your swabbing, just put your hand on the outside of your cheek and press together.
okay, like this.
Uh-huh,
I
yeah.
got it. Okay. Thank you
And
for that.
get some cells. That's what you need. And you just may have like really smooth, gums.
Well, everything with me is going to be a little difficult. That's just the
Of
way it
course.
is. So
Of course.
I always have to learn. I learn something every time about something I'm doing. So I will do that. Thank you. Okay. How much more time do you have, Dr. Herbst? I forgot to ask
I
you.
have another meeting in 15 minutes, so we got
15
15 minutes.
Okay. Is there's a diagnosis? Okay, so Cynthia
Mhm.
Strantz says that there's a diagnosis on her chart. It's obesity due to excess calories. This diagnosis infuriates her because she eats clean. However, due to gastroparesis, did I say that right? Gastro,
Gastroparesis, slow gut motility.
okay, and indolent systematic mastocytosis. Did I say that
Hmm.
right? I have loaded coffee in the morning, a snack for lunch, and a small dinner. I rarely overeat. What logic can I use to get this diagnosis deleted from my chart?
Yep. So sometimes electronic medical records give you limited ICD-10 codes that you can use, which is wrong. And they're better. They should be better now. And there are a plethora of ICD-10 codes for obesity. And I do use that obesity code, especially when prescribing GLP-1 receptor agonists. Even if I have a patient who's thin, I still use it because we're dealing with a kind of a form of obesity. And just ask them for a different ICD-10 code. I mean, there's just plain old obesity, and then there's class 1, class 2, class 3 obesity that says nothing about food. There's other obesity. So I would ask your provider to please delete that code and just put a new one in that, they know you don't overeat. So yeah, that's wrong. And I'm sorry you had that happen to you. And that is infuriating.
Thank you. That's good advice. Monica is one of our she's one of our moderators. She's from She lives in Germany.
Nice.
Buxbaum, Monica Buxbaum. She wants to know: is there any promising research studies on Durkheim's in the future? Like, is there anything that's like really new that looks promising?
Uh, Besides genetics, I mean,
There you go.
I would say not that I know of, but my very good friends at UVA, Shelley Krasinski and Sarah Algadban, are determined
Love
to,
them.
are determined to do research on Durkheim's disease. And, I am 100% supportive, and I'm hoping I can give them some hints from genetics on what to do. But I would say that they're going to do something really well, really good. And we've been sending patients to Shelley to put on her list for full body MRI imaging. And Sarah Algaban is going to take all of the samples we collected when I was at the University of Arizona, and she was there too. And she's going to write them up, just like we did for lipedema. She's going to write it up for Durkheim's disease and see if we can't gain some insight there. And then you have to talk about angiolipoma versus regular lipoma. So but honestly, I don't know of anything, other than the injections that's coming up in the near future. It's unfortunately, there's no money for Durkheim's disease research. If we had funding, or, if somebody else had funding, I'd support somebody else doing this work. That would be fantastic somehow. And I have a very good friend who known for many, 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 many years, and he has angiolipomas, and he will likely come into some money, and he is determined to do research. And he sent me this, that reminds me, this whole research thing and what we could do, and he used AI, and I need to get back to him on that. But it
His
could
name
happen
isn't
in the next
Dr.
few years.
D'Angelo, maybe.
What?
It's not Dr. D'Angelo, is it?
No,
No. Okay.
no, I
Because he
know
said
he's,
I talked to him today.
yeah, I know he is, uh, I think, could really do something big. So,
Yeah, that's
um,
why. Okay.
yeah, that would,
Awesome.
he's also, somebody we can look to for hope for the future. But no, this
Yeah,
is somebody different. And so in the
awesome.
next year, hopefully, God, it'd be so exciting, wouldn't it?
Yes, it would be. Oh,
Mm-hmm.
that is so exciting to hear.
Mm-hmm.
Okay, well, that is really good. Okay, I'm going to kind of skip through here and see if I can try to just pull some ones because we've got just 10 minutes really left here. Um, okay, let's try this one. This Ilona Sherman she's asking, I think, for her dad. She wants to know if acupuncture is helpful for Durkheim's.
Absolutely. I think
Okay.
so. Dry needling, acupuncture, cupping, negative pressure therapy, which is like cupping. It's just a little bit more intense. Um,
Sure.
myofascial release. I think manual therapies are super helpful.
That is great.
Okay, now
That
it's
is
Dr. Herbst gets to pick one. So is that okay?
yes.
Okay. This one says, there's a lot of research on lipedema. What are the similarities and difference between it and Durkheim's disease besides the obvious visual differences? More specifically, to what extent can research and treatments on one be extrapolated to the other? Well, I think it's all on the spectrum. And if you look at our first paper with Sarah Algadban as the first author, and it's the most cited lipedema paper, it showed that in 30% of women, they had these weird vascular formations that looked exactly like angiolipomas. And the way that came about was I had a friend who's got lipedema, and I said, I want to look at her sample under the microscope. So we pulled it out, and I started looking through, and I go, what is that? I go, is that an angiolipoma? And then I'm like, oh my God. I go, we got to look at every single slide again. And that's when we found out that about 30% had what looked like angiolipomas. And yesterday I had a patient with lipedema, and she has two lipomas on her body. She's like skinny little thing. And she has an angiolipoma and lipedema. So yes, there is overlap between the two. I mean, it's all fat, right? It's just that in Durkheim's disease, they tend to develop the nodular fat tissue on the trunk first. And then in lipedema, it's mostly on the lower body first. But lipedema can spread to the abdomen. It can spread all the way up the body. It can even go on the head. So yes, they're in the same spectrum. And I think whatever we learn in one, we can apply to the other, because why not? It's again all fat physiology. It's just fat physiology gone wrong. And a lot of the times, especially in like angiolipomas, it's something weird about the vasculature. And what we've been seeing for angiolipomas is that you can see the blood vessel, and then you see this little boop at the end of it. And so these things, the fat's likely coming from mesenchymal stem cells that are part of the blood vessels. And in lipedema, we have leaky blood vessels.
Leaky.
Yeah, so there's something wrong with the structure of the blood vessels. There's probably something wrong with the structure of the blood vessels in Durkheim's disease too. So yes, don't let anyone tell you any different. It's all on a spectrum.
Is that the person, Sasha Muli? Was that from the UK? Is that
I
the
don't know.
question?
I didn't put the names
Okay.
down.
Awesome. No worries. You want to pick another one?
Unless you got one. Oh, okay. This came up a couple of times about palliative care with Derkham's disease. Uh,
Mhm.
I I do think that you can get palliative care with Derkham's disease. It all comes back to a caring provider. And that's what I'm hearing is that there seems to be not as many caring providers, I guess, that are involved with the Derkham's population. If you can find one, and it doesn't matter where they're from, rheumatology, endocrinology, primary care, plastic surgery, I don't care. As long as they're a caring provider and are willing to work with you and do
Mhm.
whatever it takes to help you. That's been my motto all along. Do you want me to write you a prescription for going to Disneyland because that reduces your stress and makes you feel better? Heck yeah, I'm going to write you an order for going to Disneyland. Why not? Right?
Yeah.
So, palliative care means that you're still working to cure what you have, but you're going to get palliative care by a specialized team on the side. And I'm 100% supportive of that.
Do you have any upcoming states that you're adding?
We just added Nevada and Florida,
Okay, so
and I
through those
know,
three
I know
announcements,
Maryland. Hmm?
yeah, Maryland. That's why I asked that.
Yeah, not Maryland right now. There's just not enough people there. But if we get enough inquiries, then that's how we add states.
We have a lot in Florida.
I a
That is what
lot.
is it? I don't understand, but there is a lot there. So that
Yeah,
is a really good state to add for sure.
absolutely.
Oh,
For the European people, we used to
yeah.
have a Derkham's research group at the Karolinska Institute in Sweden. And the contact person for that group is Sue Melgrim, Melligrim. No, Mellgrim. Sorry. And she's a physical therapist. She's not a doctor, but she's knows a lot of the providers. She's very well connected. She's a delightful human being, and she does physical therapy on a lot of people who have Derkham's disease. So that's I don't know anybody else who's really able to take care of people with Derkham's disease. I'd seek her out and get a name from her. I think that would be helpful. And in terms of
Very
what helps brain fog, I use resveratrol. That's Resveracel from Thorne. And it's a combination between resveratrol, which is
good.
anti-aging, anti-inflammatory, and nicotinamide riboside, which wakes up your mitochondria, makes them work again, detoxes you, and gives you energy. And it really helps with the brain. And I'd also recommend the magnesium threonate, which crosses the blood-brain barrier. And that magnesium is needed for most every enzymatic reaction in your body, and your brain's, using up most of your
Mhm.
calories. So resveratrol is what I would recommend for that.
Great, great. Okay, well, you have 4 minutes. Um, I just want to say thank you.
You're welcome.
This means a lot to our group, and you know that they're just all in such need, and we have a lot of new members, and they're always like, who's Dr. Herbst, and we're trying to explain, and so I think this is going to be really helpful to them. And then of course you answered a lot of questions from the people that have been in our group for many years, so all the way around we're pretty excited that you joined us. I do want to say that as you know, I'm newly diagnosed compared to some of the others. Like, you diagnosed me in July of 24. So April of 24, on this day exactly, I had posted a Facebook post, and it came up in my memories that said, "Is anybody familiar with Derkham's disease?" And I got zero. Nobody responded to it, and it came up on my memories
Wow.
this morning. It was
Wow.
also the day that I laid in bed and I was in so much pain that I just said, "God, just you can just take me early, just take me, because I can't stand the pain." And it's really funny because it's like he said, "Okay, well, let me get to work then." And so it was kind of like I asked that question, and then it just, this is where how far I've come in two
Wow.
years to
That's
the day,
amazing.
and I'm doing this with you.
Ah,
It,
that's amazing.
it's full
Yeah.
circle.
Well, I will tell you, I've been interested in fat ever since I was about 3 years of age. And I got some money to do a research study on Madelung's disease, so multiple symmetric
Yeah.
lipomatosis. And I contacted a website, the only website for multiple symmetric lipomatosis out there. And the woman who ran it, Jenny, said, hey, you should look into Derkham's disease. And I'm like, Derkham's disease? What is that? So I looked into that and I'm like, well, I'll just throw it on this little grant. So I threw it onto the grant. So it was multiple symmetric lipomatosis, lipodystrophy, and Derkham's disease. And that's where it started. And the first person who called me was from Rhode Island, and she called me in January 2006, and she said, I have Derkham's disease. And I was just like over the moon that I, met somebody with Derkham's disease. And it's been, I've been in love with Derkham's disease ever since. Not that people have it, but the fact that it's an enigma, and I've been wanting to figure it out because wow, what a difference you could make if you could take away people's pain.
Yes. Was that Barbara by any chance?
It was, yes.
I've learned a lot. I'm telling you. So Lauren interviewed her recently. So out on our YouTube, there's Barbara's interview.
Yep, I saw it.
Yeah, we're very happy to have interviewed her.
She has been one of the biggest advocates for Derkham's disease in my, realm.
Oh, absolutely agree with you. And so
she's been in newspapers, she's had fundraisers, she's been online, it's just been incredible. So well, thank you for keeping the Derkham's Disease Society alive. And if you guys ever do want to take me up on the genetics, that would be awesome.
We're going to start working research in genetics, and we're going to go that direction more. We are. We know.
And if you use a different company, that's fine. That's up to you. But I can't help you because I'm only versed in sequencing.com right now because they have software I can actually use. But I would still support you. And if you found the gene, wouldn't that be great?
All right. Well, I appreciate you. I hope you have a good rest of your day.
Thank you. You too. Take care.
Bye-bye.
All right. Bye-bye.